Charmila, how does the DIPSI test translate into practice in a small town? I would feel, with my reflections, both the patients and the doctors fall in line with the recommendations in smaller places more easily than acting too smart, as in the metros. That is really what I have found. So what has been your experience and your thought process, Charmila?
Thank you so much, ma'am, for inviting for such a great program. And as Dr. Kasturi ma'am said, we have all been exposed to your sensitization for almost 15 years. And we have been following that for a long period of time. My city, we actually conduct camps for rural health, rural women also, because I'm attached to an organization which has got self-help group women, lots of them, like 20,000 something. They conduct camps. And you'll be surprised to see almost a prevalence of 30 to 40% of undiagnosed diabetes, even in rural women. Yeah. And my setup, we don't do a selective screening, we do a universal screening. We do the single step DIPSI procedure, and we do it in the fasting and non-fasting. And you found out that the prevalence rate is more than 30%. It's not less. So by doing this type of testing, we are not missing out on women who need those lifestyle changes. Like, we are not jumping into medications at once. We see those women on the borderline. Most of them are borderline because I think there is something percolated into the community and lifestyle has changed a little bit, but borderlines are more. And when we advocate those lifestyle changes, it has caused a great impact in the mother as well as the baby. We see those short-term benefits also. And I hope we have got a data collection of these women, and we hope to see the good benefits in the babies also when they collect or when they do the proper method of treating themselves, because we advocate a self-monitoring. We keep on counseling about how to control themselves rather than coming to us for checking their sugars. And anything goes wrong, we ask them to call over the phone and talk to us, so that there's no problem in compliance, because the compliance is the biggest drawback when we counsel women with those borderlines, because they do not have any symptoms. So it's very difficult to tell them what's going to go wrong with the mother and the baby. So, but when you tell it correctly and ask them to do it at home, they do it quite well. And you've seen a great benefit. And I hope to provide data to you probably in the next 5 years regarding these women of how the benefits is translated into practice. And the other thing is, in Manyata, when we're doing the assessments, we found we used to teach every paramedical person about DIPSI, and we taught them quite well. But when it translates to assessment, we find in the metro cities, there is a bias towards doing these tests. And I may be biased, but I feel that practitioners trained abroad has got that reluctance compared to one who's trained in India. And I tell them it is not the Royal College or American College you need to follow, because it's an Indian population. We are totally different from the rest of the population, and that they need to follow this. And we have got complaints once we talk to them personally, but otherwise I find there is a block there in metro cities compared to the smaller cities. Practitioners in smaller cities are quite compliant, and they want to follow what is right.
So it's like the truth be told about what is the ground reality. When you said Royal College and American College, we have somebody from the Indian College, the immediate past chairman, Dr. Uday Thanawala, who so kindly joined us, because Uday always says, I'm always there for you, Hema, and here he is. Thank you, Uday. They're just going around the kind of thought process which I had discussed with Uday in the recent past, just about 3-4 days ago, that I need the voices of all our champions and the leaders on each of these issues related to hyperglycemia and pregnancy, and also a message to the lay people, so that at the end of this program, when we get the link, we are going to make the 2-minute video snippets for circulation, because saying it once is not enough, and we need to keep on hammering this again and again. And Diamonds Are Forever, the series which Uday has created, maybe that gave me the thought process that, okay, we also do something which creates a constant video buzz. So thanks, Uday, for joining us once again. So as I said, Charmila, just one small question. You said in the villages there are your outreach camps, but do you test only the pregnant women, or you'll test the entire population, which means that the pre-pregnancy and also the 35 plus women who are there, do they also have the sugar testing? If so, is there any hesitancy? They're saying, oh, nothing is wrong. I have no symptoms. Why should I come to your camp and get myself tested? What is the thought
Madam,
process in the minds?
in Tamil Nadu, we are not supposed to test pregnant women in camps, madam. So we don't.
Okay.
So we do for the age group of 25 to 45 because those are the
Excellent.
women who are those in that self-help groups actually.
So
we
most
found
importantly, so do they hesitate to come and subject themselves for the test?
No. I heard somebody else talk also. Women are quite receptive. I think Bharati said that. Very
Excellent.
receptive. It's a practitioner who has to change the mindset and think the patient is not going to accept. When you talk to them correctly and tell them about the transmission to the baby which is going to happen, they will be very receptive to doing the test, because when it comes to the baby, Indian women, I think, will leave everything for the baby's sake. So once you tell them you have to manage your diet and exercise for your baby's sake, they do it quite comfortably without any problem.
Excellent. So I think this is a point very, very well taken, because the entire village, the girls and women in that age group are tested. I think it will go a long way in tapping the undiagnosed cases for an early care.